and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Teri Schreiner, MD, who will be talking to us today about managing pediatric-onset MS with lifestyle, medications, and teamwork. After a presentation from Dr. Schreiner, we'll open it up to your questions and answers. Now I'm delighted to actually introduce Dr. Schreiner and let her tell you a little bit about herself. Thank you.
Thank you, Deborah, and thank you all for joining today or for logging in at your convenience. My name is Teri Schreiner. I am a neuroimmunologist from Colorado. I am the director of the Neuroimmunology Clinic for Children at Children's Hospital Colorado and a researcher both at Children's and at the University of Colorado. I'm an educator. I am an administrator at times, but foremost, I am a clinician who takes care of children, adolescents, and even some young adults with multiple sclerosis and related diseases. And it's my pleasure to be here today and to talk about managing pediatric multiple sclerosis from a multidisciplinary perspective. What I'll do first is share my screen. I do have some slides and I will take you through those. If you have clarification questions as we go, please let us know in the chat. I will be very happy to take your questions either as we go or at the end or both. Thank you for being here today. So as I mentioned, this is our title and our task for today, to talk about these. I'll start with some disclosures, which is standard practice, just to let you know a little bit about what I do and how that may be influencing what I tell you, though hopefully not. I do participate in some research related to multiple sclerosis that is funded by pharmaceutical companies. I am a consultant for the CDC and the Colorado Department of Public Health, and I am on what we call a data safety monitoring board, which is a way of monitoring research that's done also in the realm of pediatric MS. Now, presumably you are logging on today because you already know about MS, multiple sclerosis, but I'm going to just bring us back to the very basics before we dive into more specifics to say that multiple sclerosis is demyelination. What is that? Well, it's taking the myelin off the axons in our brain through inflammation at different times and in different places in your brain. So on the left-hand side of the screen, you see a calendar with some dates circled. This is to indicate that maybe there have been 2 episodes of demyelination in this calendar year. And on the right, you see some white spots on a brain, indicating maybe this is where those episodes of demyelination or inflammation have occurred. So again, at the simplest level, MS is separation in time and space. And we know that MS usually affects adults. The average age is in the 20s to young 30s, generally female, but somewhere around 5% of all patients with multiple sclerosis are diagnosed when they are less than 18 years old. And this is what we call pediatric onset MS. And these are not my patients. These are pictures that I have just found online of young people with multiple sclerosis who have told their story and shared their picture. And as you look at them, you will probably find no difference between, the children that you know in your life and the appearance of these children. But we know that when you're diagnosed with a chronic disease in childhood or adolescence, it has a different meaning than when you are diagnosed as an adult. And nobody wants to have anybody diagnosed with multiple sclerosis. But when you're diagnosed as a child, you're still in those formative years of trying to figure out who you are, how you are going to relate to others. There's a strong sense among a lot of teenagers, maybe you can recall, of wanting to kind of be like other people. And having a rare disorder, as it is in this age, can be an incredible challenge. And so it necessitates a multidisciplinary approach that I'm going to tell you about, and also a lot of patience and understanding for what these children and teens are going through. Now, multiple sclerosis, when it happens in kids, we believe is the same disease as when it happens in adults, but it does have a few distinguishing features that I'll tell you about. So one is there's a typical way for MS to present in kids, and this is by no means a rule. Absolutely not. But in general, more patients present with optic neuritis, that inflammation of the nerve that connects the eyeball to the brain, with brainstem syndromes, again, inflammation in that very inferior part of the brain that connects the brain to the spinal cord, and encephalopathy, which is just doctor speak for confusion, kind of just abnormal behaviors. Sometimes it's a lot of sleeping. It is not being yourself. Unlike adults who sometimes have a course that progresses gradually, almost 100%, and I would lobby for 100% of kids with MS have a relapsing and remitting course. That means it comes, it causes a problem, the kids recover, go for a period of time, but then may have another problem and then recover, and so on and so forth. This is the relapsing and remitting course. And it's inflammatory, big time. So kids with multiple sclerosis may have 2 to 3 times more attacks on an annual basis than an adult would in those early years of disease. And this may speak to the strength and ability to overreact of a young immune system compared to an old. Whatever the etiology, this is something we need to know about and be prepared for, because it influences how we think about treatment for pediatric patients. Now, in the short term, kids have excellent recovery. They have amazing cognitive reserve. That sort of ability to compensate for things is incredibly robust in childhood. But as I'll show you a little later, each attack does matter and can contribute to more difficulties as the child ages. This is what it looks like. These are MRI pictures of brains of children with multiple sclerosis. And without knowing a lot about MRIs, I'll just direct you to the white spots that you see in panels A, B, and D and E, and the dark spots in C and F, and say these are the areas where we see the MRI appearance of inflammation. This is where we presume there is demyelination occurring. Now, there have been a lot of terms used for these white spots. I like spots because it's uniform, but lesions, plaques, these are all referring to the same thing. Areas in the MRI, on the brain MRI, where we know that there is inflammation going on. So who gets MS, particularly who among the children get MS? This was a question among many that we at the network of pediatric MS centers sought to answer. And this is a consortium of clinicians and researchers across the US, as you see, who treat pediatric MS and participate in a database registry. And that means that we add information about our patients into a centralized registry so that we can ask questions like, who gets MS? And this is some of the results that we published a couple years ago. So we see that while pediatric MS refers to anybody less than 18 years old, there is an increase in the age or the incidence of pediatric MS as kids get older to that 18-year cutoff, so to speak. What we also see on the left is that the very young kids, the prepubertal kids with MS, they're pretty well balanced between boys and girls. That as you see the age progress along that x-axis, you see those red bars increase in height. That means there are more teenage girls getting MS than there are boys in the blue. The ratio of girls to boys increases closer to what we see in adulthood. This has probably got some hormonal, or is the manifestation of some hormonal changes. Now, we also see on the right a little bit more information about where these patients are born. Now, we know ancestry is something we refer to a lot when we are talking about adults who get MS, where your ancestors from. In pediatric MS, it seems to matter more where they were born. And so you see the preponderance of the patients in this cohort, this group of patients that the consortium has contributed to. Most kids are born in the US. Now, their parents may have a more diverse ancestry, but most of the patients, the pediatric MS patients in this cohort at least, are born in the United States. Now, the million-dollar question, why does anybody get MS? But certainly, why would a child get this usual adult onset disease? And not surprisingly, this is another area of research for the network of pediatric MS centers and countless of other researchers as well. And broadly speaking, we think this is some combination of genetics and the blueprint that has been passed down generation to generation about how to build our bodies and how to run them, and a combination of the environment. So what viruses have you been in contact with as you've been growing and developing? How much sunlight, how much exercise, what are you eating? All of these things are what we consider the environment. And there is some sort of interplay between the genetic blueprint that we have, the DNA, and the environment that we see as children. And there are different examples of this, but I want to make one cautionary note before we go on to speak a little bit more about genetics, which is that nothing here is absolute. So you may be looking, if you're a parent of a child with MS, you may be looking at this diagram and seeing a Big Mac and thinking, oh my gosh, why did I let my child eat that Big Mac? But it's far from simple. These are just concepts that we know play a role. But if it were as simple as eating a Big Mac, we would have figured that out a long time ago. So this is complex. I don't want any interpretation too much into this diagram, just to show that there is this interplay of the genes and environment, which is playing a role. Now, I've mentioned this is not clear. It's not only that, it's kind of muddy. But what we know is that our genetics determine how our immune system functions. And our immune system is what contributes to inflammation. And so what you see in front of you is called a circus plot. Now, this is a visual representation of gazillions of different genes analyzed between almost 50,000 patients with MS and 68,000 people without MS, trying to look and see whether or not there's any proof of the genetics in MS. And what these researchers found a couple years ago is that there are 233 genes that are more likely to be represented in someone with MS than someone without MS. Now, that is far from straightforward. 233 is a big number. But when we think about why kids get MS, one of the suspicions is that maybe there is something stronger about some of these genetic changes for children, allowing the disease to manifest earlier. And that's one area of research, is trying to figure out how, again, the genetics and the environment may be different in these patients who can present a decade earlier than the average adult with the same disease. So, so we know a little bit about who gets MS. We know a little bit about the why, and just a little bit. But now let's talk a little bit about what MS in a child can do. We know it's not good. Inflammation in the brain is not something that we welcome, at least not to this degree. But what does it mean to be a child with MS? I'm showing you some graphs here from a study that was done in France before there was good treatment. So we have treatment for pediatric and adult onset MS now that would make this study sort of obsolete. It would be uninterpretable. But before we had good treatment, these researchers followed kids and adults diagnosed with MS over a period of time to see how they did. And keep in mind, these are untreated patients. And what they found was, or what they studied specifically, was how long it took to get to a place of having enough problems walking that you needed to use a cane or a crutch. And what they found on the left, what this diagram shows us, is that it took 28.9 years after diagnosis for a pediatric patient to get to that place of needing to walk with a cane or a crutch. That sounds like a really long time, and it is, but take a look at the next graph. The one on the right shows the age at which these children reached that point, and it's only 42. 42 is pretty darn young. And so this study tells us that, yeah, although kids recover very well in the short term from their attacks, they matter. Those attacks matter because over years, there is an accumulation that can lead to a disability like needing to walk with a cane. And that can happen at a really young age. And as someone over 42, that 42 seems even younger now. So this is data about untreated patients. We're going to talk about how we treat MS now so that hopefully this data is just history and we don't have to think about that for our patients. So what can be done? Well, this is a diagram that I'm borrowing from one of my colleagues to introduce this concept of neurologic reserve. And I mentioned it earlier in the talk as well. The concept that a young brain can recover really easily from insults. It can compensate for what happens. That's the reserve. It's kind of like the the money that you keep in the bank. You have a lot of money in the bank as a young person, and over time, you're spending it, you're getting less, taxes go up, whatever, but your ability to recover from these insults becomes less over time, and that can have manifestations in cognitive function, motor function, and sensory function. Now, we want to do everything we can to preserve our neurologic reserve. So I'm going to ask you to join me in an analogy here. The analogy is that your brain, really anybody's brain, but particularly someone with MS, your child's brain, someone you know, your brain is a castle. Okay. Now, you see a little brain here in the middle of the castle representing, this analogy. Your brain is a castle, and you have different things attacking your castle. Think medieval, England. You've got the MS army that is sending in inflammation to break down your walls. You've got regular attacks on your castle that include aging and trauma and illness. And what we want to do to preserve your reserve, your brain health, is defend that castle. We defend it offensively with things called disease-modifying therapies. These are medicines that are used to calm down the attack, to really just take out, those MS armies at the knees. And there are lots of different kinds. There are injectables, there are pills, there are infusions. Getting into all of that is beyond the scope of what I want to present today, but I want you to think conceptually about this idea of defending your castle with an offensive strategy, using these medicines to help with the defense. But another part of protecting your castle is lifestyle. And lifestyle is a big deal. So whereas, on the offense, we might be using medicines, the defense is really the lifestyle, diet and exercise, and building up those ramparts, making those walls stronger, repairing any holes you've got so that your brain, your castle, is able to continue without any long-term sequelae of the attack. So how do we stop the attack other than medicines? Well, one is, if your child with MS is in a home with smoke, that smoker's got to stop. So it is hard. I am not saying this is easy, but there is good evidence that shows that smoke damages not only the lungs of the person who is smoking, but also affects the immune system, the disease process of MS patients who are exposed to that smoke. So the secondhand smoke matters, and we want to minimize that. Again, we want to minimize any attack on the castle. One of the attackers is smoke. If the child with MS has any other chronic conditions, we want to maximize treatment of those as well. Again, this is treating the whole child, and taking care of anything else going on is going to matter. And then preventing injury. And this is pretty straightforward. It's not news, but helmets are required really when on anything with wheels. We have to prevent the risk of attack to that castle from any trauma, because although it's a different attack on the brain, it still affects your cognitive reserve, your ability to maintain a healthy brain with resiliency. So let's talk a little bit more about how to fortify your castle. So we mentioned treating any other illnesses you've got, minimizing smoking, wearing a helmet, protecting your brain. Other things matter too, like here, treating any mood symptoms. I'll visit this again a little bit at the end of the presentation, but unfortunately, depression is common in MS, and it is not just an adult MS problem. It affects kids as well. Treating mood symptoms does fortify the castle. It contributes to overall well-being and lifestyle, and it matters. A healthy diet matters. We'll talk more about that. And exercise matters as well. So here's a little bit more about depression. It gets to be a sticky business because MS can also cause fatigue. Fatigue can cause depression, but depression can cause fatigue, cognitive impairment. All of this can really, feed on itself and create someone with MS that's really in an unhappy place. And so targeting each of these things, focusing on mood, very important. And thankfully, depression is responsive to treatment. And I'm not just talking about medicines for treatment of depression, but talk therapy as well. Thankfully, it is very responsive. Now, the diet in MS. There have been a lot of studies about this, and I am asked regularly by my young and my adult patients, what's the right diet to be on for MS? And there are lots of things to choose from. So one of the better known diets for MS, called the Swank diet, was very low in saturated fat, and it did over time have a lower mortality rate. It seemed like, the bee's knees, this is what everybody needs to be on. But on closer scrutiny, there were some challenges with it, like the fact that it's sort of unsustainable, and that over time, the number of people able to follow this disease, even in the study that was published, became much smaller. And so the data was a little bit skewed by those really dedicated people who held on to this diet for a long time. That being said, a diet low in saturated fats probably still makes sense. High fat diet has been associated with relapses, specifically in the pediatric MS population. So we definitely want to avoid that. And we have mouse data as well that shows that a high fat diet can add to inflammation. So we want to think about a healthy diet that has lower reported disability and depression. We want to focus on hydration because there are studies that correlate hydration with less fatigue. Now, there are also other studies that have correlated a different diet called the paleo diet with improved fatigue. Other studies still have said, no, what you really need to do is restrict your calories. That is anti-inflammatory, and that has neuroprotective effects. And, while you're at it, we need to pay attention to cholesterol too. So does this mean that all pediatric or other MS patients need to be on a paleo, plant-based, gluten-free diet with restricted calories and intermittent fasting? No, 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 no. That would make everybody crazy. Parents, children, doctors alike. But what I recommend to my patients is this. We need more vegetables, more fish, more water, pretty much across the board. We need less saturated fat, trans fatty acids, sweetened drinks, salt, cow's milk. I haven't even gotten into dairy, but those are on the less category. But I think we really get into trouble when we try and come up with absolutes, particularly for a pediatric and adolescent population. These are concepts that I think are actually attainable and can still have a big effect. Exercise is, different, the definition according to who you ask. But I put up a definition here, which means that it needs to be something planned, something thoughtful. Many people are active in their life, but exercise is something different. That is dedicating a period of time to physical activity for a benefit to your overall wellness. And the benefits I've listed there are not new to anyone, but this in particular for pediatric MS has benefits to mood, cardiovascular health, immune function. And again, the immune system is the bad guy if we're oversimplifying with MS, but we still rely on it to keep us healthy. So we need an immune system that is functioning properly, and exercise can help with that. So here are some of my priorities, sort of summing up this castle analogy and the lifestyle priorities, is to think about a disease modifying therapy, talk with your doctor or your child's doctor, treat anything else, prevent injury, wear a helmet. And then from a dietary standpoint, less of that, more of this. Exercise, maintain a healthy weight. There are studies linking childhood obesity to worsened course with MS. We don't want that. So exercise and healthy eating are all part of this priority. Now we've talked about sort of what is MS, who gets it, the why, at least what we know so far, the lifestyle changes that are important. Lastly, I'd like to talk a little bit about the teamwork that is necessary. So this is my multidisciplinary team at the University of Colorado and Children's Hospital Colorado. I'm going to introduce you to the different members of the team and the role that they play, and advocate for why I think this multidisciplinary team is essential. So for one, I put nurse and program coordinator at the top of the list because truly nobody's kidding anybody here. Like, we need somebody who has his or her eye on the game and can bring all these people together and coordinate the care. It is oftentimes to the program coordinator, which may or may not be a nurse at each site, to make this all happen. They are really the glue that helps every team function together. And that is no different for the multidisciplinary PEDS MS team. So we need the glue, we need the nurse or the program coordinator holding us all together. We need the providers. Within my neuroimmunology clinic for children, the PEDS MS multidisciplinary clinic, we have 2 MD providers and 1 physician's assistant. We all work together. We all know the patients. We all manage their care, and that provides a team approach, and also allows for sort of cross coverage. If one of us happens to be unavailable, everybody knows everybody else and can help with the patient care. Now, I'm going to introduce you specifically to a few of the different members. So a neuropsychologist is a PhD doctor who studies the function of the brain less from a motor standpoint, sensory coordination standpoint, but more from a cognitive standpoint. How is the brain functioning in many domains? You know, multitasking, frontal lobe functions, short-term and long-term memory, visual spatial processing. These are all very particular domains that have tests that have been standardized and thus can assess cognitive function over time. Now, why does this matter? Well, sadly, pediatric MS can have cognitive sequelae. And I've shown you here some data that came out of a very good Italian study, which was, done over a long term, looking at pediatric MS patients and their cognitive function over time. And what they found was that unfortunately 30% of the patients in their cohort had some change in cognition within a few years of diagnosis. And that is something none of us want to see. So again, this is having a neuropsychologist as part of the team provides a focused assessment of how the child is doing cognitively, which can be even more sensitive than asking a child, how are you doing? What are your grades? You're going to get very different answers. This is the very quantitative way of assessing how someone's cognitive function is doing, which is an important part of putting together all the pieces and saying, am I treating this child appropriately? The next member of the team is a psychologist. Now, a psychologist is different than a neuropsychologist. A psychologist is a mental health professional, and they are the providers that really assess relationships, stability at home, behavior, what are your emotions like, how are you coping? And I can't speak enough to how important it is to have a psychologist as part of the team. I could tell you countless stories of how I've gone in to see one of my patients and said, how are you doing? And they say, I'm great, everything's fine. And the parents say she's great, everything's fine. And then the psychologist goes in and actually figures out how things are really going. And those two stories are much different. The psychologist is a skilled professional who can help to really make sure that the child or adolescent with MS is getting the right care. On our team, we have a social worker, and this is someone who wears a lot of hats. But as we can imagine, as you may know, there are a lot of needs that come up in the care of a child or an adolescent. And the social worker is got a really sort of multifaceted role of trying to target those needs, identify who can meet the needs, and then put all of the necessary people together. That's how our social worker functions. And this is invaluable because we don't know all the resources out there or how to connect them. This is someone who has the know-how to get things done and has been really invaluable to our team.
Excuse me, Dr. Schreiner, I have one question
Yes.
on that. The psychologist and the social worker that you use,
Yeah.
they specifically pediatric psychologists? Are they trained for specifically to work with the pediatrics?
Yeah, so thank you. That's a great question. So within my team, they are pediatric focused. And I am describing the members of my team not as, the only model out there, but I'm really fortunate to have so many specialists or pediatric specialists together, really providing care to these individuals from all of these different perspectives that I'm describing. It is not necessary to have someone who is specifically pediatric focused in these roles, but I think that it does help. And again, that kind of gets back to where I started in saying these kids have different social pressures, have different self-identity, have different challenges than they will have, 5 or 10 years later. And so having someone on the team that's familiar with those particular challenges, I think is very valuable. But it could certainly be someone, a psychologist who sees, the full age spectrum. Okay. Now, part of my team is the research component as well. Now, research is scary to some people, but it shouldn't be. It is the process whereby we, study patients, study treatments, study interventions to really make sure that we are providing the best care. We may think we are, but if we don't study it, then we don't necessarily have the data to say, yep, this is the way to do it. And so within many, I would say most academic centers, the research is a really integral part of the visit because it allows patients and families to feel like they're a part of something bigger. And it can allow us to partner with them in helping on a more global scale to learn more about the disease. Research never happens without consent. It is always optional. But I think sometimes it is helpful both for the patient and for the parent to think, okay, like I know there are a lot of questions that we don't have good answers for, and hopefully my child's information will help to get to a place of having more knowledge. I think this is something most people have seen before, but I really think it is true that the team, the multidisciplinary team that I've described really achieves more than any one of us could alone. And so with that, I'd like to thank you for your attention. I'm happy to take any questions that you might have. Maybe what I'll do is I'll stop sharing my screen and then see if we have any questions in the chat, or Deborah,
Yeah,
if you've received any.
we do. Let me give a couple directions for those that aren't familiar with the system. That was a fabulous presentation, by the way. Now
Thank
that
you.
we're ready for questions, if you have one or a comment, please use the raised hand feature in the app, or you can just send your question via chat. Some of these are going to be from Facebook. But if you want to raise your hand, you click on the screen to pull up the menu, you select more, which is that little icon with the 3 dots, and you click raise hand, and then I'll unmute you. And then you have to allow me to unmute you. So anyway, okay, we can start. We had somebody contact us a little earlier, and it's from Jason, and he wanted to know, what do you think brings on MS in one sibling, but not the other, when genetics and environment are really very similar?
Yeah, I think that's a great question. And actually, it's been studied. They have done studies of identical twins. So siblings who have the same genetic material and have grown up in the same home and theoretically had the same viruses. There's only a 25% concordance between them. And so what that means is that it's not the whole story. So the blueprint may be the same, but how the body is reading that blueprint and how the environment may be turning on some things and turning off other things is different, even between those identically or identical siblings. And so it's proof that genetics matter, because when we look at siblings who are not identical twins, the concordance is much less. It proves there's a genetic component, but it doesn't tell us the whole story because it's not absolute. So it's a great question. I wish I had a better answer.
Thank you. Casey, I see that somebody has their hand raised, but I can't really see who that is. Do you see who it is?
Yes, that would be David. And David, I'm going to unmute you or give you the option to unmute yourself if you would, please.
Thank you.
Hey, David.
You have a button that allows you to unmute yourself.
Hi, Dr. Schreiner. I really enjoyed your presentation on pediatric MS.
Thank you.
No problem. 24 years ago, I was diagnosed with MS and I was 14 years old.
Yeah.
And so all of the things that you just talked about, I was like, the optic neuritis, and I have to have a castle. And the thing is, the encouragement to a lot of the MSs out there is that we have to have that castle all over our bodies and know that we have to eat right, we have to do this and that, and we can still make it out there. And that's how I am able to. I'm 38 years old now. And so I didn't know all of what you talked about back then. I was 14 years old. And so I really enjoyed it. It just had a nostalgia that I went back 24 years.
Well, thank you for your kind words, but you've lived it. Everything that I've described, you know firsthand. So I take my hat off to you.
Yes. Good job. Great job. And I'm happy to be on this call and listening.
Thank you.
By the way, Dr. Schreiner, David has been on many of our Zoom conferences, and he is from the Bahamas. He generally tells the doctor, this time he didn't.
Oh,
that's an interesting fact to tell you.
Wonderful. Okay, well, welcome. I'd love to be in the Bahamas with you.
It's beautiful. It's beautiful. Sun, sand, and sea. You know, everyone needs to come to the Bahamas. It's wonderful.
That's another component of lifestyle I didn't mention, is having a wonderful vacation at least.
Even though it is that way that we have MS, and there are so many of us out there that has MS, and I've met people from other islands in the Caribbean that have MS. So it's like MS is all over the world. And so the youngest person I've met as well was 16 years old. And I mean, other than me, I'm 40, it was 14, he was 16. So it's like you have to do your best. You have to go there and just make it happen. And so that's what it's all about. And eat right and do your research and all of that stuff. And so all of the stuff you talked about, hands up. all hands off. So
Thank
good
you,
job.
David. Thank you,
Thank you, David.
Yeah, man.
Okay, let's see. So now I am going to ask, Casey has a question. She said, what do you recommend for parents who want to be proactive in terms of helping kids with MS with problems that they might be facing in school?
Oh, I think that's a great question. And I see fatigue, cognitive problems, excess. Okay, great question. So there are resources available online that speak specifically to conversations you should have with the school, you know, what expectations to set for your children. I think that in my practice, what is foundational to all of this is the neuropsych evaluation, because it really, in a very quantitative, objective way, says, here are the things that this child can do very well. These are the things that are challenges. And that is the food for discussion with the school. And I think that it really should be a discussion, because the accommodations that might make sense for one child are going to be pretty different for the others. In general, I think all kids should have a 504 plan. A 504 plan is an agreement between the school and the parents that say, okay, I think this is what the child is going to need. And it may be sitting in the front of the classroom, extra time for test taking, extra time between classrooms, more frequent trips to the bathroom, whatever it may be. But I think that having a 504 plan is a really important first step. I think that a discussion that I recommend having between the parent and the child very early, soon after the diagnosis, is who are we going to involve in this diagnosis? So for example, say hypothetically, I'm a parent that wants the whole world to know what I'm going through and what my child is going through. But my child might be someone that's like, yeah, I'm trying to just blend in here. Like, I don't want anybody knowing my business. That family, my hypothetical family, needs to have a discussion about who is going to be involved in the diagnosis, who's going to know and how. The only advice that I give is that I think someone at the school needs to be within that inner circle, even if the child is feeling very private about sharing their diagnosis, because the school is such an amazing part of a child's life at this age. And it is the place where these difficulties with fatigue or cognitive function may manifest. And so having a partner there at the school, I think, is really important.
Okay, good. I have a question. Do you refer many of your patients to Oscar the Monkey group?
I do. Yes.
Yeah.
Yes, there are a lot of resources out there. Oscar the Monkey just had their camp, which is great. It is a network for kids and teens with MS where they can, interact with one another and really feel that they are part of a community, because even though this disease is rare at this age, there is a community of people out there, and they are they can normalize everything that a child is feeling, which may be isolation, anger, frustration, confusion, all of that. There are, incredible strengths to be had from having a peer to talk through things with. And, when they're on a medicine that nobody else has ever heard of within that community, they've heard of it. And that can be very powerful as well.
I agree. Just for those that haven't received their magazine yet or have not ordered their MS Focus magazine from us, this particular spring issue, I believe it was spring, the last issue that just went out and should have been received or will be soon, was regarding pediatric MS. And Dr. Schreiner actually wrote an article in there for that. And many of the kids that we met through Oscar the Monkey, wrote articles themselves. So it would be a really nice for anybody listening who has children with MS, get them to read the articles. It was very inspiring, really super inspiring. And if you would like to receive one of our magazines and are not on the list, it's the most inspirational, educational, and motivational publication, I believe, in my own personal opinion, that we create, and we do a lot of good ones. It's awesome. And if you're not on the list, just simply send back the email, refer to the email that we sent you, and tell us that you'd like to be put on the list, and we'll contact you, give us a contact information. So we'll make sure to put you on there. It was really great. And thank you for doing that article also.
You're welcome.
Okay.
Very glad to be part of it.
Let's see, if we don't, Casey wants to know, if we don't live in a community with a pediatric MS center, which is a very good question, how do you get the appropriate treatment?
Yeah, that is a great question. So I think that so if you can get to a pediatric MS center, I think there is benefit to going at least once to, people like me who do this all the time and are well versed in all the different aspects of it. And there is a list that you can find at it's the US US NPMSC Network of Pediatric MS Centers. So www.usnpmc.org. So the US Network of Pediatric MS Centers will show you where the pediatric MS centers are and whether or not one is accessible to you. So that's one option. If it's just not feasible, and I get it, sometimes it's just not going to be, I would find a neurologist close to you who may be an adult trained neurologist, but someone who knows more about MS than a different neurologist who knows a lot about dementia, Parkinson's, movement disorders, like whatever. There are a whole bunch of subspecialties out there. But an adult neurologist who knows more about MS is still going to know a lot about the medicines available and how to use them, when to dose them, what tests to give and at what intervals. And so if it is not feasible to get to a pediatric MS center, then I think sourcing out a adult neurologist with an MS specialty, I think will be a really good sort of center of the care. And then maybe trying to put some of these other pieces in place locally. A neuropsychologist, a psychologist, having a meeting with the schools. I think all of this can be recreated outside of a specialty academic center. It just takes a little bit more doing to get it all put together.
Thank you. We do have a couple more minutes. If anybody has a question, you're welcome to raise your hand or send it through our chat. We'll wait just a couple seconds and see if anything comes in, something on somebody's mind at the last second. You pretty much covered everything. Oh, let's see. I think that's about it. Okay. Well, I thank you so much for all your information. That's all the time we have for now. If you've missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be this coming Thursday, August 26th at 4:00 p.m. Eastern Time. Our speaker will be Dr. Marco Vespignani, and his topic will be Supplements for MS, What You Need to Know. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Schreiner, who was kind enough to answer all of our questions today, give us a wonderful view of pediatric MS. Have a great evening, everyone, and we hope to see you again soon. Thank you, everybody.